All right. Good morning, everybody. Welcome to Rounds on this pre-Thanksgiving day. I'm Dr. Jamie Miller. I'm one of the staff pathologists here at Coplow, and I will get started with our first couple of cases. Go. So the first case is the left eye from a 1-year-old female intact Polish rabbit. Um, who has a history of having a very slight chronic left-sided head tilt overall. And the left eye was reported to have hypopyon and hyphema that was non-responsive to Baytril and afloxacin. The ocular diseases have been progressive over the past 5 months, and there was no definitive known trauma that occurred. They do note that the ocular changes started at the same time as the head tilt, so that is interesting. The rabbit was dewormed with panicure and otherwise systemically healthy. So this is our hemisected view of our formalin-fixed globe. We've got the cornea oriented at the top. Here's our lens in the center here, and we have the posterior portion of our eye here with the optic nerve in the back. So what we can see here is we do have some pigmented tissue that kind of lines the posterior portion of the cornea. So presumably this is the iris tissue that is kind of broadly adhered to the back of the cornea. Our lens is a little bit cloudy, and then you can see this white opaque material that seems to be extending from the anterior surface of the lens and kind of filling this portion of the globe. So, rest of the eye wasn't too terribly interesting grossly, so let's look at this histologically. Great. So again, here is our cross-section of the globe, cornea again oriented at the top, kind of like the gross photo. And we can see that what we saw to be white grossly is this dense purple infiltrate here. So there's something that is hypercellular in this portion of the eye. Again, we can see that pigmented tissue, that's iris tissue, contacting the back of the cornea. And we can see our lens, front of the lens is a bit irregular, and you can see basically lens fibers coming out of the lens. Here is our retina back here, which we can see looks a little bit atrophied on this one portion here in our optic nerve. All right. So I'm going to start up at the cornea first, which is here. Get it in focus for you. So actually, there was a little bit of separation of our epithelium from the corneal stroma, and it had this eosinophilic material underneath it. So we have a little bit of subepithelial bulla formation actually here. We can also tell that there's a little bit of an infiltrate in the corneal stroma itself, and these are heterophils. See these nice little eosinophilic granules here in these mononuclear cells. There's also some blood vessels infiltrating the corneal stroma as well. So we got a little bit of a keratitis. And then if we kind of fall back into our what would be our anterior chamber, we can see a little bit of some iris tissue here, and we can start to see our irregular portions of lens fibers. Let's see if I can find you. Here we go. So here is our lens capsule. It's our thickened portion of the lens capsule. So this is the anterior side of the lens, and we can see that it is discontinuous. And we can see all of these liquefied and degenerate lens fibers that are extruding out from the lens cortex and into the chamber here. And these lens fibers are accompanied by a mixed population of heterophils and macrophages. Here. Some of these guys are big and foamy. Occasionally, some of them are multinucleated, and there's a lot of phagocytosis of debris and stuff in here. And then if we keep heading backwards, here is our posterior portion of the lens capsule. So the lens capsule here gets kind of thin, and we can see that there's lens epithelium that has posteriorly migrated, which is another cataract degeneration form. And again, more cataractous features in the back of the lens. And then, as we sort of noticed from subgross, our retina here is quite atrophied, which is a little bit interesting, especially because it was a bit segmental in nature here. Even heading out peripherally, it kind of starts to come back, which is a little bit odd. Usually the peripheral retina is a bit more atrophied with aging, but this is a young rabbit. So, and then we have some nice gliosis in our optic nerve. So lens capsule rupture in a rabbit, especially young one, with all of that heterophilic and granulomatous inflammation, we start to have an idea of what potentially caused these findings. And so this is a gram stain, looking for a very particular organism, which I have marked because they were a little hard to find in this case. But so you can kind of make out thick portion of the anterior lens capsule. So I'm inside where the degenerate lens fibers are. And we can see these gram-positive staining microorganisms. So that's the closest I can go. A little microsporidian. They're, I can zoom a little bit. There you go. So these guys being here in the lens with everything else going on with this rabbit is pretty suggestive of infection with encephalitidae species. Mature cataract with the lens capsule rupture and all that heterophilic and granulomatous phakitis, and endophthalmitis, and then the intraocular and even probably more specifically intralenticular gram-positive microsporidian, again, consistent with E. cuniculi infection. Infection with E. cuniculi would also kind of offer an explanation for the head tilt because that can affect the brain as well as other organs such as the kidney. Likely infection was probably in this young rabbit transmitted vertically, where the microorganisms will enter the lens through the fetal vasculature and then cause cataract development and eventual lens capsule rupture and then the associated inflammation. Let's see. And then, yeah, like I said, that region of retinal atrophy was a little unusual, but possibly it could represent a glaucomatous lesion. There certainly was reason that there could have been glaucoma in this rabbit with all of the changes up the lens and pupil block and all that stuff. They said glaucoma was unknown for this rabbit, so just a potential possibility for that. Any questions, comments for this case?
Comment a little bit on how does that happen?
The vertically transmission through the fetal vasculature, kind of in utero during development.
Yeah. How old is it again?
1 year.
Yeah, that
was your 4 day. So
perfectly said.
Yeah. Cool. Right. So next up, we got both eyes from a 7-year-old male intact golden retriever dog who has a history of being diagnosed with uveitis about 3 years ago and developed glaucoma about 2 months ago. So clinically, they described in the right eye, which is over here, that the eye was blind, had some corneal endothelial degeneration and moderate corneal edema with some hypostria. They noted a small ruptured cyst on the corneal endothelium, which I think might be that there. that they also noted some iris cysts in posterior synechia with some incipient cataract formation and glaucomatous changes in the retina and optic nerve with vascular attenuation in the retina and a dark optic nerve. The left eye, again, was pretty similar clinically with the addition of having some hyphema. And they couldn't really see much of the deeper structures, but they noted a history of multiple iris cysts in that eye. So they took both eyes out. I don't have a gross picture of them, but grossly they were both ophthalmic. The lens was kind of cloudy in both eyes and subluxated in the left eye, as they reported clinically had a little bit of uh, hyphema and hemorrhage in the vitreous. So both globes were fairly similar histologically, kind of like they were clinically. So I'm only going to show one. Red spot here. This looks so. Oh, I bet I know what happened. I'm still zoomed in from when I was showing you guys the microsporidian. Haha. There we go. Now we can see most of the globe. All right. So again, cornea oriented at the top there. We have our iris leaflets here. And it's probably a little bit hard to see from the subgross view, but we start to see little whispers of like little membrane formation on the ciliary body and a little bit here on the lens capsule. Here's a little bit of hemorrhage, and we can see some cupping of our optic nerve, which is more glaucomatous change. We often take an extra radial section of the globe to further evaluate the iridocorneal angle and other structures in the eye. So that's what this extra piece here. And again, you can probably see a little bit better here. You'll start to see this membrane formation coming off the ciliary body. All right, so here's our cornea. We can see it's kind of a little bit thick and irregular, and we'll go take a little closer look at that in a minute. Here's a little bit of that settled hyphema. We've got some membranes kind of crossing this angle here, causing peripheral anterior synechia. Again, here are some of those membranes that are on the ciliary body, lens capsule, a little bit of hemorrhage. You can see some pretty good retinal atrophy here ventrally with some evidence of some pedal sparing. So we can still see most of the layers dorsally compared to the ventral side. And then here's that extra slice. This is the one that I just like this one the best. So these membranes are composed of this thin attenuated spindle cells that often have this eosinophilic basement membrane production associated with them. So these are iridociliary cysts that are very thin-walled with these attenuated cells, which are characteristic of a golden retriever uveitis or pigmentary uveitis. So again, we can see similar cysts on the lens capsule and kind of multifocally on the ciliary body, again, with some of that basement membrane production. You can also see them probably, oh, that's probably still ciliary body. The iris does have some attenuated cells kind of on the anterior posterior aspects of it. Some of these might be collapsed iridociliary cysts. Here's a little look at the little fibrovascular membrane that's kind of crossing the angle here, causing posterior peripheral anterior synechia. And we've got some pigmented cells here dispersed in our trabecular meshwork. So we've got a little bit of pigmentary dispersion as well. And then similar to the membranes kind of on the iris, we've got these membranes and doubling here of the posterior cornea of Descemet's membrane. And sometimes you can even pick up some pigmented cells sort of in between these layers. So there's probably collapsed ruptured cysts that are on the posterior cornea here, which is something that they, again, were appreciating clinically as well. And then just to finish up, they had noted habstria, which is a little bit of stretching and breaks in descemet's membrane. And so here we have a nice sharp edge here to our descemet's membrane with a little gap, with a little bit of some cellular reaction here. So this is consistent with some habstria. And then I think just to finish up, the lens also had some cataractus change here. So again, the posterior portion of the lens capsule here, which is thin, and then we have posterior migration of our lens epithelium. Then we have some degeneration, liquefaction, and some Morgagnian globule formation of the lens fibers here. So some early cataract formation. Again, findings were similar in both eyes, so I'm not going to show the other eye. So I thought this was just a nice example of our golden retriever uveitis with all those thin-walled cysts lining the ciliary body, iris, and lens capsule with secondary glaucoma, probably from the membrane formation and pigment dispersion and such, with a little bit of cataract formation in both eyes. So, yeah, it was just a nice classic case.
Yeah, and for those who are not aware of this entity, especially, pathologists, I think ophthalmologists are very aware. Might be asking yourselves over there, why is it called golden retriever uveitis if there's not a single lymphocyte in that eye? So the term uveitis here comes from the clinical presentation of flare and things floating in the ocular chambers that the clinicians see. It's not, from the pathologist's standpoint, it's not uveitis because there's really no inflammatory cells. By the time we receive it, you can have the exudative phase of inflammation with, protein exudating the chambers and floating around, but it's not mainly in inflammatory disease. And it really doesn't really look like much histologically, when you see all those just thin membranes all around, but it's kind of a devastating disease for the eye, let's put it that way, right? Because, these animals, these golden retrievers, and we've seen similar lesions in other breeds also will eventually develop glaucoma and they have to be enucleated.
Yeah, it's most commonly a bilateral disease, especially in the golden retriever dogs. So if we only get one eye, it is something that we're obviously warning the clinician about. Most of them know, but just to keep an eye on the other eye that it's likely going to develop glaucoma since it's likely having the same process going on in the remaining eye.
Yeah, and the name of the disease is confusing. So golden retriever uveitis, it's confusing because it's non-inflammatory. Some people call those pigmentary uveitis, which, again, it's kind of confusing name. It comes from the release of melanin and all the membranes that you see, but as we saw grossly, it goes more than just melanin release. You got those membranes and the walls of the cysts causing everything to kind of adhere to, the iris adherence to the lens and peripheral anterior synechia, etc., that blocks the aqueous drainage.
Cool. All right, I will make way. I think there we go, or not.
All right. My name is Leandro Teixeira, pathologist and the director of the lab, and I'm going to be showing you the next two cases. The first one, it's pretty obvious what's going on here. This is let's see, how old are you, buddy? Sorry, we have a 14-year-old mixed breed dog with a history of severe ophthalmos and panophthalmitis, complete necrosis and granulation tissue of the cornea, and a visible pigmented mass effect at the dorsotemporal sclera. Um, they describe in terms of the duration more than a year of the disease, but more pronounced changes occurred in the last 2 months or so. Yep, so this is what we received. It barely recognizable as an eye, but let's get some of our bearings here. So we got one of the eyelids there. We got here's the limbus. We got cornea. There's this white infiltrate expanding the cornea and the anterior segment of the eye. You can see how it extends into the opposite side of the sclera right there. We have haired skin here, so eyelids. So everything is sort of blending out together here. And inside the eye, there's this obvious heavily pigmented mass like lesion. If you follow the sclera here, you'll also see that there's a defect right there, right? It's discontinuous. And you got some optic nerve right there. And it's very solid, dark mass. It has, we were joking in the lab the other day, it has this, it almost appears like a cross-section of liver or something like that, right? So one of the things that we don't see here is the lens. It's not obvious where the lens is. Um, let's get a closer look to it. Okay, histologically, so here's the subgross appearance of this tumor. It's pretty big, so we'll have to move around a little bit. But nice correlation. We got that eyelid section that we saw, right? A little bit of the third eyelid coming up right there. So we know that this is ventral. It's easier to see or to try to start appreciating what was cornea. So here's corneal surface. You got the epithelium, a little bit of stroma left, and that white infiltrate corresponds to these areas right here. You see we're going around. A lot of this is artifact. Um, a big tumor like that sometimes doesn't get completely fixed when just you immerse in formalin like that. So a lot of the stuff we're seeing here is artifact, either a fixation or tissue necrosis. A little bit of lens right there, maybe a little bit of lens capsule here. We follow the other side. Here's more eyelids. Beautiful row of meibomian glands right there. So this is kind of eyelid margin. Coming around, here's the sclera. And we go to the other side, some mesomineralization. So we have these, and starting to see maybe meninges, and so we're closer, we're close to the optic nerve right there. So there are two main patterns here. There's this large pigmented portion of this eye or this lesion, and there's this less pigmented change that we're seeing more superficial. Let's take a peek and see what's going on here. Eyelids, to find ourselves. Okay, so just to confirm, this is this ocular surface, so corneal epithelium, right? Some corneal stroma markedly infiltrated by maybe some inflammatory, well, I would say inflammatory cells, fibrosis, and all this other stuff. And then we have Decimus membrane right there, right? So we know that anything from here on is intraocular. Maybe very obvious to say that, but it's useful to get a sense of where we are. Now, when we move around, things change a little bit, right? There's really the only identifiable, well, we got corneal epithelium, maybe a little bit of pre-existing corneal stroma, but then we have this population here, right? You have these anastomosing cords and trabeculae of cells. They're surrounded by more like a mesenchymal reaction. Right, we keep going around, you see that there's more of them, and here they become a little bit more obviously neoplastic and more obviously epithelial, right? Why do I say epithelial? Well, first, these cells have no business being here, right? So we know that that's something wrong. Second, we got cords and trabecular cells forming this cystic spaces filled with, this cells that are detaching probably, or, degenerated cells. Um, they have kind of tied, they're kind of cohesive, tightly attached to each other, right? So we're not talking about round cells, and they have an oval to round nuclei and relatively good amounts of eosinophilic cytoplasm, right? And see how they form these trabeculae everywhere. We have pretty obvious nucleoli everywhere. There are mitotic figures all over the place. Here's a beautiful one right there, right? And here and there, if you look around, you can start seeing what looks like a basement membrane surrounding these cells. So those are features of epithelial cells. So if we go back, there's a lot to cover here because there's a lot going on in this eye, but we're going to sample it here and there. If you go back to these cells right there, they're a little bit different, but we're still talking about the same or a similar process. They still look epithelial, right? They're forming these cords and nests. And all this stuff that we're seeing around is what we call desmoplastic reaction, which is a reaction that we see associated with carcinomas or malignant neoplastic cells of epithelial origin. So they attract or they produce, they stimulate the stroma to proliferate around and forming this kind of supporting stroma. So desmoplastic or Skir's response, right? Which I think probably is one of the reasons why we saw that very thick and white infiltrate on low magnification. Okay, then we start looking around. Very necrotic. This tumor is kind of weird, is doing weird things. There are areas like that where there's this dense eosinophilic extracellular matrix. It looks like collagen, but it's flirting with maybe a basement membrane, maybe an osteoid matrix, like these guys are producing osteoid, but you can see how linear that stuff is. So let's keep that in mind. You move around and, well, the maybe osteoid becomes obviously osteoid. So this is bone, right? And how do I know it's bone? Because it's mineralizing and you see, some cells getting embedded there. So these are osteocytes. We got some osteoclasts in there. So there's a deposition of osteoid. This is beautiful. Look at that. These are osteoblasts, kind of like you would see in a cortical bone or a medullary bone, right? So this tumor is also stimulating the formation of heterotopic bone, which is weird. But if you thought the weirdness is over, we still have to deal with the fact that there's an enormous black mass filling the whole eye, right? So here it's basically all necrotic. The reason I say necrotic, let me just show you a higher magnification there. We get the silhouette of the cells in the background, but they're all eosinophilic and you don't see nuclear details. So this is ischemic necrosis. But there was a lot of melanin associated with the necrotic area. So we're probably dealing with either necrotic uveal tissue or a necrotic mass. And then you start moving around and then you get to the other side. And all of a sudden, okay, this is less necrotic, more identifiable tissue. And then we do have a heavily pigmented, what looks like also neoplastic population of cells. The first thing one thinks when we would say, heavily pigmented melanocytic neoplastic population of cells in the eye is a melanoma. And wouldn't argue against anyone that wanted to say that here. But when you look around, you start seeing that the cells in the background, they do also form, or they keep some of that cord and trabecular-like appearance. So we were suspecting that this part of the tumor is also epithelial. And then you ask me, wait a minute, a pigmented epithelial tumor. Well, yep, especially in the eye, we know that there are a few epithelial layers in the eye that are pigmented, like the iris and ciliary body pigmented epithelium and the RPE cells. So we have seen cases of iridociliary tumors or tumors from the iris and ciliary body epithelium that can be pigmented like that, but we were not super convinced yet. Okay, then again, we were just in the intersegment so far. We haven't even got to the back. So areas of necrosis and mineralization. There are these extensive areas of fibrosis in the back of the eye, probably maybe related to that area of scleral rupture that we've seen before. But then you look at these cells and they don't look like they belong here either. So potentially part of the neoplasm. Yeah, if there are any questions, just shout it out.
There's just been a comment said so far they've considered 3 different tumors.
Good.
So
I'm glad we are all on the same page. Sometimes all we need is to show a kid to someone so we can all be confused together. You know, then you look at these areas of fibrosis, it's pretty dense, and there are some of those neoplastic cells kind of in between. So this could be fibrosis from the scleral rupture. This could be more of the desmoplastic reaction. But there was one area that I thought it was relatively useful. If you keep moving around, now look at that. Two worlds collide. Now we have an intersection where we have the clear, more epithelial neoplastic, or more, sorry, more, yeah, well, why was it doubting? The more obviously epithelial neoplastic component of this neoplasm with the more pigmented component right there. And we keep moving, and there's an area where I hopefully will find, yeah, kind of right here where you can see how I think it's more believable that we have a pigmented epithelial neoplasm right there. Right. So having a pigmented epithelial neoplasm is not that big of a leap in the eye. You know, it's believable just because we have seen pigmented iridociliary adenomas or partially pigmented iridociliary adenomas. What we have to deal with here is the whole thing, like what is going on with this eye? Because this tumor is everywhere, it's facing the eye, it's infiltrating here the sclera, causing a scleral rupture, right? We know there's a history of very chronic disease. They said something about what was that? More than a year, or more than a year, but there are more than a years that the first time they've seen this was more than a year. So we don't know how long before that. And there's a lens capsule rupture. I showed you a little bit of a piece of lens nucleus here. There's some lens capsule floating around. So potentially some trauma associated with this tumor. We don't know. But one thing that we decided to do was a PAS stain. So a PAS stain, in this case, remember we were talking about those basement membranes that are associated with epithelial neoplasm. So we want to see if we can highlight those basement membranes with the PAS. Here is a Decimus membrane, which is, here is Decimus membrane. No, A in terms of like, every eye has one, but here's, this eye is Decimus membrane, right? So it just shows a positive control for the PAS and what basement membranes should look like. To be honest, also, sometimes we will get a PAS which we call the, well, let me think about this case PAS. So you order a PAS, and then you come back and you get a little different look at it. But in this case, we thought it was very useful because you can see, so this is that classic epithelial population of cells, and it's showing pretty neat looking basement membranes. In this case, not any basement membranes, but these are very thick, irregular basement membranes, like we see with iridociliary tumors in the eye, right? But we were kind of happy with this population here being epithelial, right? We'll get to it later, but just saying any epithelial neoplasm can have basement membranes, right? So if you have a metastatic carcinoma to the eye, it could have basement membrane. So we're talking specifically about these thick and irregular ones, kind of like that. Another useful thing that we can do when you look at these areas of necrosis, right? So basement membranes are extracellular matrix, so they don't die, right? You can kill what's never been alive. The cells here are all dead, but if you look at the areas of necrosis, you can still see the leftover scaffold of those basement membranes in the necrotic area, which confirms that all the necrotic tissue was once the neoplastic population. So this is just the leftovers of that. And then going back to that more pigmented area or the more pigmented tumors, you still have the same very thick PAS positive basement membranes throughout that part of the neoplasm, the pigmented portion of it. And if you go back, it gets even more impressive here. This is actually very pretty. PAS also works I often joke, as a chromotherapy. So if your life, having a hard morning, just look at it for a little bit and just makes you a little happier, right? So you can see all this very thick basement membranes. So that, look at that. That strongly suggested, strongly said, that helped us in a nudge towards our differential diagnosis of a tumor of iridociliary origin, right? But this is no mere iridociliary tumor. This is what we call, what's called what we classified as a pleomorphic adenocarcinoma, right? These are truly malignant neoplastic processes of the iris and ciliary body. We classify iridociliary epithelial tumors as adenomas, carcinomas, and then we have the pleomorphic adenocarcinomas. Um, of those three, the pleomorphic adenocarcinomas are the only ones that are truly malignant that can metastasize to other areas of the body. We cannot completely rule out a metastatic carcinoma to the eye. I know Kelsey Brakel is online and she's been looking at those cases, and we have some conversations about there potentially being some other things that we call pleomorphic adenocarcinoma being metastatic carcinomas from other areas. But this one, because of the presence of that double population, the pigmented and non-pigmented population, and those very thick basement membranes, we think it's more likely to be a primary malignant ocular tumor. Another thing that helps, the history is it's good for these tumors, like chronic ocular disease. A lot of the tumors that we diagnosed with pleomorphic adenocarcinomas had either history of chronic ocular disease, a clear history of trauma, and some of them had a history of gentamicin injection, intraocular gentamicin injection. That is done in the eye as a last-ditch effort to kind of cause a chemical destruction of the ciliary body. So the ciliary body, in cases of glaucoma, the ciliary body will stop producing aqueous and the IOP will decrease. Usually it's done in eyes that are already blind, right? It's just more like for comfort. And one of the things that I think that we think might happen is that gentamicin is cytotoxic. That's the only actual reason why you use it, because you want to destroy the ciliary body epithelium. And we think in some cases there might have been an unidentified benign tumor inside the eye, and then there was a gentamicin injection done, and the gentamicin kind of caused what we, affectionately call angrification of the tumor. So that tumor that wasn't as bad becomes even more, becomes more malignant and can start looking like the pleomorphic adenocarcinomas. Question?
Yes, there is a request that if there's time, could you show the PAS of the round pigmented mass and the other neoplastic epithelial cells in the cornea?
Yes.
Portion.
The pigmented portion in the cornea, is that what
Yeah,
you're saying?
in the cornea.
Okay.
And then there's also a question is if we know if there was any staging done for Mets, since there was
No,
rupture.
we didn't. The clinical history is very brief and very ocular oriented. they were suspecting a melanoma, melanocytoma, on a clinical history, but we don't have any information. Well, the only information on general medical conditions we have here is a geriatric patient with minimal veterinary history.
Okay. Yeah.
So we first thought that that meant that the dog was kind of healthy.
Mm.
There's not much, but then we also potentially thought, well, probably never seen a veterinarian, and this has been going on for a long time. So
Unlikely to have a gentamicin injection.
right. So is this population you're talking about? So the epithelial corneal?
Yeah, in the cornea, I think.
Okay, so this is that population of cells that's infiltrating more the limbus than anything else. Okay, so it doesn't really like the black, so the camera here has a little harder time with the black. So here's Decimus membrane, a piece of it, just to confirm. And you have these kind of basement membranes going around. Um, let's go back to an area where it's less pigmented so you can see. Here we go. So you can see basement membranes spread all over. They're not as thick as the main ones, but then you got areas like this where there's necrosis and you get some of the collapsed stuff maybe surrounding it. I don't know if that's the area that the person wanted to focus on, but does that satisfy?
Yeah, I think if there's anything else you wanted to show, you could speak up. We do have a couple more comments or questions. Does the pleomorphism diagnosis cover the heterotopic bone aspect in this tumor?
Heterotopic bone formation, I think it can happen on those neoplastic, in this neoplasm. I don't think it's a feature of it. And in some cases, I think it's more, has more to do with, or probably associated with the deposition of the very thick extracellular matrix and some mesenchymal trigger there that causes that tissue to become a bone. We do see bone formation in iridociliary carcinomas and in some adenomas too. So there could be that or some pre-existing mesenchymal stem cell. Get it?
So we see it in the non-crazy ones. Like
Yeah, we've seen them on crazy ones. So it's not that abnormal to see that in iridociliary tumors.
And there's a population of cells like towards the left, maybe like the non-pigmented portion that's in the cornea.
Oh,
Maybe
so
that-
yeah, so these are
Yeah.
beautiful ones in the pigmented
Mhm.
portion, the more the necrotic one. And they want to see the non-pigmented portion.
I think as well. Yeah, probably. put
Okay.
this in.
So here's that one in the corner. Here's that part that has like the more like the scurus response. And you can see some of that here, but it becomes pretty neat at that more obviously epithelial right there. Look at that. We did offer immunohistochemistry. They did not answer yet. We would go and do that.
Dr. Breaker has a comment.
Yeah.
She said that they had a suspect pleomorphic iridociliary adenocarcinoma yesterday that was positive for melon A and PNL2.
All right. Yeah.
So
Well, famous last words are, this doesn't look like a melanoma, right? And then the thing becomes a melanoma right in front of you because melanomas can do like whatever they want. I mean, I'm gonna go there. This doesn't look like a melanoma, but you know what I mean? I wouldn't be surprised if a melanoma can kind of mimic this.
you may also just be suggesting that it would be actually very difficult to differentiate the two
I agree.
definitively.
Yeah, yeah. Yeah, and that the reasons we'd offered IHC, but we didn't go for it. Sometimes we do things on our dime. This is a very large slide.
What did you offer?
I think we offered. Did we offer though? Let's see. Yeah, so the keratin and vimentin, and we discussed offering NSE, but then NSE, you know, will probably stain everything here. So, and then the only reason we didn't go ahead and do it is because this is one of the large slides, and it's way more expensive to do it on that. So we were waiting to see if the owners would go for it.
I think the scariest response would make melanoma much lower anyway.
I agree.
And the epithelial arrangement is
Yeah, it's pretty
really
obvious.
not typical of melanoma. So melanoma is pretty low unless it's a collision tumor,
Right.
which happens, but
I'll be more concerned with a metastatic tumor to the eye causing something like that. It doesn't explain the pigmented portion of it. Again, if you want to argue the fact that there might be two tumors here, I don't think we can go against that. But anyway, took too much time. I mean, it deserves that much time because we discussed this case a lot in the lab too. So I thought it would be a good one for us to bring over here for us to talk about.
Yeah, Dr. Branco commented that they were running melon A on their sample because some have a minimal basement membrane production with the PAS, and they were skeptical about the pleomorphic irregularity diagnosis. But it seems like this one has a ton of basement membrane production, so goes along with that.
Cool. Yeah, they're not as obviously epithelial as this one. Sometimes they can be very mesenchymal-like. Okay, next case. Kitty cat. This is an 8-year-old American short-haired cat with a history of uveitis, purulent debris in the vitreous, and glaucoma with 59 IOP. So pretty straightforward clinical history, and can't agree with that. So here's the globe, cornea, iris, lens, and there is a lot of what looks like a suppurative exudate in the vitreous. Got the optic nerve. I think the retina is detached here somewhere, and what we're seeing here is some of that debris on the surface of the exposed choroid. So try to be a little faster with this one. It's also a pretty cool case, but we want to give Helium some time to show her cases too. Okay, here's the subgross. So lots of proteinaceous exudate in the anterior chamber. We got the cornea, got the lens, iris, and ciliary body, and you can see that most of the inflammation is centered on the posterior aspect of the eye. So this is a pattern that I think is important to recognize of a chorioretinitis/vitritis and endophthalmitis, right? But it's mainly the inflammatory reactions mainly affect the posterior segment of the eye, which for us, it suggests either a contaminated penetrating trauma coming from the sclera or something systemic spreading to the eye through the choroid and retina, right? So we will focus kind of in the back of the eye right away for time sake. So this is what we got. So that proteinaceous exudate, a little bit of, contractually obliged inflammation here on the iris and ciliary body, as one would expect, but most of it is in the back of the eye. And as I mentioned, so here's the optic nerve. If you follow there, we see these lines here. It's really hard to recognize them as retina, but believe me, that is the detached and necrotic retina. Try to get a little closer just to show you. We can see some ganglion cells there, some photoreceptor nuclei. And if you follow the vessels, you might find kind of the retina. So we're following the vessels here, a large vessel right there. So you can see already that the retina, subretinal space, vitreous, and the choroid are markedly infiltrated by inflammatory cells. Not only infiltrated, the retina is actually effaced. And right away, we got lots of neutrophils, lots of macrophages in the background, some neovascular profiles. So we're looking at a pyogranulomatous inflammation, which suggests something infectious. The retina disappears. So there's retinal necrosis. and everything becomes a sea of pus. So degenerated neutrophils, and has anyone seen anything yet? Anyone caught anyone's eyes already? Kind of dirty background, right? So we're going into an area where there's lots of degenerated neutrophils. But here and there, like what is that? So let's take a look in that. Do you guys see it now? Right? So this structures are not supposed to be here to begin with. Second, they were very useful because they brought their own colors, right? So they are already sort of brownish, which, brown to amber, I would say, but helps distinguish from the background. And what do they look like? Got these linear structures, they're septated, right? And they branch out, right? These are fungi, beautiful fungal hyphae, right? Um, the diagnosis of fungal hyphae histologically or identification, or IDing the species and genus, etc., is kind of hard. But this one has a big clue, which is the fact that it is melanized. So we know we're dealing with a group of fungi that are called demachiaceous fungi or pigmented fungi, which are saprophytic fungi that can cause infections as an opportunistic uh, organism, right? Um, the presentation, as I mentioned, of fungal hyphae in the vitreous affecting the back of the eye, affecting the retina and the choroid, and the vitreous here is strongly suggestive of a systemic disease. So very likely this cat has a systemic infection with these fungi and it ended up in the eye. Might be tempted to think that this is part of it because it has the same color, but this is just the tapetum of this cat. I think there were a few pigmented hyphae. You can see here in a cross sections, sometimes inside some macrophages in the choroid, which suggests that's where they're coming from. So we diagnose a systemic infection with a pigmented fungi or a phaeohyphomycosis. So ocular phaeohyphomycosis. So as I said, the demachiaceous fungi are a group of pigmented fungi. They have melanin-like material. I always like to go back to the origin. So the demation is like small cords, like little ropes, is the diminutive of dema, which are bands. There are many genera that these fungi can be of many genera, Bipolaris, Cladophilophora, Exophila, or Alternaria. We cannot make that distinction morphologically. We need a culture. Sometimes we will do PCR. So Phaeohyphomycosis is the name or the class of the process itself. So when you have a infection with pigmented fungi, wide spectrum of clinical presentations, right? It can be disseminated, end up in the eye like that. The cutaneous form receives specific names like chromoblastomas or eomycetomas, right? But you can have systemic infections also from that. The interesting part here is that they tend to be opportunistic agents, meaning they will cause infection in animals that are susceptible. And one of the susceptibility factors could be an immune deficiency or immune suppression. We don't know if this cat had anything in that regards because there's no clinical history, but FELV, FIV, or any other, immunosuppressive treatments of any other form could cause or predispose the animal to develop that. Questions there?
Question was the breed again on this cat. Was it a
Breed?
purebred? You said American Short.
American short-haired cat.
Yes.
So, dog that was born in the US and has a small or a short coat size, which that's the thing about cat breeds, right? You don't know what that means in terms of a genetic population or makeup of these cats.
I think there might actually be a purebred American Shorthair, and they're a little bit squishy faced.
Okay.
So it might actually be a purebred cat. I'm not,
Yeah,
it's hard to
right.
say, because like,
Yeah.
right, domestic versus American
Yeah.
Shorthair, who knows?
Who knows
Yeah.
what that means?
Yeah.
Cool. What do you say, Gabe? Want to give it a try, or you good?
Nah.
Okay. Well, thanks everyone for showing up on this pre-Thanksgiving rounds. Happy Thanksgiving for everyone out there. If you're traveling, safe travels. Hope your travels, if you're flying, are not as problematic as one might expect. And we'll see you guys in 2 weeks.
Lots of happy holidays being passed around.
Right.